All right, so I'm going to talk a bit about where do we stand. And this section is genetics, proteomics, and functional testing. I was asked to focus on the genetics piece. And I'm going to instill a bit of, I think, reality of where we are in terms of genetics. This is my opinion, but I want us to be, I'll say at a high level, very encouraged around where genetics can take us, but we also have to be very realistic when we're talking about complex disease.
There's a distinction from a regulatory perspective. There's a clear-cut distinction between prognostic biomarkers and predictive biomarkers. Prognostic biomarkers help us identify those at risk. Predictive biomarkers help us identify whether we can therapeutically modify that risk. So what Jessica is showing you is that there's a weak prognostic marker because the hazard ratio of 1.3 is barely above the phenotypical signal-noise ratio. Yeah. But what is unique about it is that despite being a weak or a modest prognostic biomarker, it's a very powerful predictor biomarker.
Well,
and that's what clinicians
the other way.
So what that I absolutely agree with. What I was trying to tease out even further is that a diagnostic, right? So diagnostic, prognostic, and predictive they're all just different. And the first part of the talk was teasing out diagnostic and prognostic, and now, so this is prognostic, and now we get to predictive.
And this is what clinicians care about.
Right.
We don't care so much about prognostic. We care about whether
height versus cholesterol. Height is a risk factor that's not modifiable.
Right.
Whereas cholesterol is a risk factor that's modifiable.
Right, and then the question is where are you on the spectrum? So once you already have a coronary calcium score of 800, are you off the grid, right? Or here you try to think about things where you catch someone early enough that your treatment will make a big difference. And this comes up a lot in the diabetes space with the treatments around diabetes. So if you look at saxagliptin as one example, there's some, if you catch patients that are too far down, once you intervene with the treatment, are you going to modify disease? And that's where I just want us to start thinking about whether it's an imaging modality, whether it's genetic, whatever the modality is, capturing people early enough that we can actually modify disease. And I think that is one place where genetics may have an advantage, is that it gives us insight into what is happening downstream. You're not just looking at the functional consequences. Although I'm a big fan of actually looking at the disease, you know what you're treating, so you're not having to scratch your head, but this may give us a timestamp, some time perspective.
Jessica, have you adjusted for family history of coronary disease in the prognostic and the predictive value of genetic testing?
Yes, so it's really, that was the first thing that we did, because if you can just ask someone, that's pretty cheap. As it turns out, where I can say it was independent and incremental. I would not have been shocked if the association went away, but it
this is the premature coronary disease or any family history?
Premature coronary disease. So,
One more yes. If you're not thinking of it as Dr. Kaur pointed out, a genetic risk score which has clinical utility, do you think this score would have been even more powerful if you had a marker in there which predicted statin responsiveness?
yes, although, so we spent a fair amount of time trying to
I don't know.
look, yeah. So,
KIF6 or
yeah, so the KIF6 came up, but that has been, there's some question there. ApoE ended up being the best variant we could find. There were whole genome sequence studies that were looked at. We looked at a panel of 100 SNPs. There was some modest benefit, and I think you bring up a great question. When we think about genetics, are we thinking about genetics of the underlying disease burden, the pathobiology, or are we thinking about response to therapy? I actually think it's much easier to study response to therapy. And so looking at the SLCO1B1 variant and some of the toxicity with Symvasan, that's brilliant work. I mean, that to me is really, it's clear, the mechanism's clear. If there were genetic variants that were very predictive of statin response, then that I think would be very helpful. And so as you say, it's the disease and then it's the treatment. So in the last minute, well, I'll just say one word on whole genome sequencing, because I know someone's about to talk. This is where we're going to be going. This is going to be an option. As I said, we're going to have to deal with it. We're going to have to figure out, not should I order a test, but how do I interpret the test. This was an interesting study that came out by a lot of different investigators, including those at Stanford. And they looked, this is obviously an early study, but did feel like at this point there was some incomplete coverage, low reproducibility, and it just highlights that work needs to be done. But this is going on now. It's going to be here. Labs are up and running. So I just encourage us to stay ahead of the curve and keep exploring. So finally, so where do we stand? I was asked from a genetics perspective. They're just different scenarios. What are we doing with Mendelian genetics, complex disease genetics? Samir brought up, importantly, pharmacogenetics and then whole genome sequencing. It just depends. Whole genome sequencing is excellent for some outlying cases that you would never find with other techniques. I'm sort of saying it's one part of a comprehensive evaluation. Let's get rid of the genetic exceptionalism. And the paradigms are changing, so we're going to have to be ready to interpret these findings. Thank you for the
Thank you
invitation.
so much.